Welcome to the Mountain West AETC Project Echo. I'm Kent Unruh, and I'd like to turn it over to our speaker for the talk today.
Good morning, everyone. It's always a pleasure to see everybody Thursday at noontime and see recognizable faces. I've been given one of these talks in a little bit, and Brian assigned me the non-occupational HIV post-exposure prophylaxis after new guidelines were recently released just last month by CDC. So I'll present these guidelines, which can be obtained by going to the website at the bottom of this particular slide. They were updated on April 18th, and the last version of them was in 2005. So I will talk a little bit about the clinical effectiveness of nPEP, and I will bring forward some clinical studies, some animal studies, performing a risk analysis when somebody presents after an exposure or potential exposure to HIV. What are the preferred and alternative nPEP regimens that are recommended in the new guideline? A schedule of laboratory evaluations that are typically done for people who have had an exposure, handling other STIs, which is really pretty straightforward. Just a word on special populations. And then this was brought up just in one of our recent noontime conferences. What about moving from a post-exposure prophylaxis to a PrEP scenario, and how should that transition happen? Some issues that I had with the new guideline that I think might be worth talking about, and then a summary statement. So this is just some data on clinical effectiveness. Remember that there's never going to be a prospective randomized study, a placebo-controlled study after an HIV exposure. People are, not ethically going to ever agree to going on to a placebo after a significant exposure. So we have to take our data from retrospective analyses and uncontrolled studies. The first is this analysis that was done on healthcare workers who were exposed to HIV and were treated with AZT or not. And that collection of cases revealed an 81% reduction in transmission. Among gay men, there's been one nPEP failure. This is someone who really did get 28 days of PEP after an exposure to HIV and suffered a seroconversion that was late. That patient also acquired hepatitis C after that episode. And we'll talk about the consequences of co-transmission in just a few minutes. There have been 6 studies totaling over 1,500 patients after an HIV exposure that got non-occupational PEP, and there were 48 failures, although most of them aren't really failures. 40 of the 48 had ongoing risk factors, and 35 of those 40 seroconverted 6 months after the exposure. So those failures probably represented infection after a second exposure that wouldn't have been handled by the nPEP that the person received. Among those 8 other cases, 1 was infected with a slightly resistant virus. 3 cases provided no information on the timing of the PEP or the regimen choice or adherence, and 4 again had delayed seroconversion, raising the specter that they acquired HIV after their PEP treatment. There's been one Brazilian study, 200 exposures. Patients were given a 4-day starter pack followed by a follow-up visit for 28 days. And in the group that took the starter pack, there was only a single conversion. And of the people that did not take the starter pack, there were 10 who acquired HIV. Again, some evidence that getting on therapy quickly after an exposure provides some protection. After sexual assault, there's lots of reports of this, but the studies are really quite limited. They have limited baseline reporting of HIV status, limited reporting of nPEP completion and follow-up. Nevertheless, there have been no reported cases of HIV transmission after sexual assault. And then a variety of other mixed exposures in other populations, sexual and non-sexual exposures among children, adolescents, and adults. 15 of 19 studies had completed nPEP regimens, and there were 19 transmissions, but only 1 nPEP failure. The others had incomplete nPEP or ongoing risks for other reasons that they might have broken through and had a failure. And then we also take our cue from vertical transmission studies, but remember these are hard to isolate the effect of the PEP that the infant gets, because the mother is also getting some treatment either during their pregnancy or peripartum, and then there might be ongoing breastfeeding afterwards, so repeated exposures to HIV. So it's hard to isolate that one exposure that happens at birth and the effects of treating the infant after that exposure. I thought it would be worth just looking at some of the animal studies that also underpin the recommendations and the effectiveness of post-exposure prophylaxis. The first study that was done was published in Science in 1995. This was macaques who were exposed to SIV by intravenous injection and then were given daily subcutaneous tenofovir starting either 2 days after the intravenous injection, or 2 days before, or 4 hours before, or 24 hours after the injection. And in all cases, tenofovir alone, when delivered subcutaneously, provided perfect protection against the acquisition of SIV. For those monkeys that did not get any tenofovir, all 10 became infected. So there is this 28-day recommendation, and where does that 28-day course come from? I think from this study, which again is another animal study. 24 macaques were intravenously inoculated with SIV and treated with subcutaneous tenofovir at various times relative to inoculation, and also for various durations. So you can see here that those that got treated 24 hours after inoculation for 28 days, there were no seroconversions in that group. If you truncated the PEP to 10 days or 3 days, but again 24 hours after the inoculation, then most of those animals became infected. So I think this is the data upon which we rely for the 28-day course after anyone suffers an exposure to HIV. The other question is, where does this 72-hour break point come from, after which, it's thought to be relatively ineffective, the use of PEP? This is another animal study. In this case, 16 macaques were challenged intravaginally, so not intravenously, and were inoculated with HIV-2, not HIV-1, if that makes a difference. And they also were treated with subcutaneous tenofovir at various times relative to inoculation. So those animals that got treated 12 and 24 and 36 hours after intravaginal instillation, none of those animals seroconverted, and in none of those animals did you see evidence for HIV when looking for proviral DNA in their lymphocytes. If they waited for 72 hours after intravaginal instillation, then one of the animals did seroconvert, and one had PBMCs that also had DNA. But in 2 of the animals, it was also still protective. That's why I think this 72-hour breakpoint is a little fuzzy. So let's just do a case. A 21-year-old gay man who was celebrating his birthday and was taken to a local bathhouse after closing down 2 bars. He remembers little according to his friends. He engaged in receptive anal intercourse with several anonymous partners. 3 days later, he noticed some dysuria, urethral discharge, and some rectal discomfort. He presents to the STD clinic and is diagnosed with urethral and rectal gonorrhea. He is concerned about contracting HIV and asks about post-exposure prophylaxis. And the question is, how do you advise them? To advise them, you need to know something about the risk of him acquiring HIV from someone who, in cases where the source patient is known to be HIV positive. And these are data that are compiled from a number of studies and are in the recent guideline of the risk of acquiring HIV per act. So for people who get a blood transfusion from someone who's HIV positive and not on therapy, the risk of acquiring HIV is almost 100%. After needle sticks, it's 0.6%. Sharing needles, 0.6%, or needle sticks, 0.2%. For sexual exposure, the riskiest act is a receptive anal intercourse, where the risk per act is about 1.4%. Receptive vaginal intercourse is less, and insertive anal intercourse is around the same as receptive vaginal intercourse. Insertive vaginal intercourse is even lower. And the guidelines back away from assigning a risk per act for receptive oral or insertive oral sex, just saying that it's quite low. But I'll show you some data on that in a little bit. I think it maybe isn't as low as the guidelines would suggest. So besides looking at the sex act, you also have to look at exactly what happened during that act, and then what was the status of the source patient. So for substantial risk, it would be any exposure of mucosal membranes or non-intact skin or percutaneous route with blood, semen, vaginal secretions, rectal secretions, breast milk, or any fluid that had visible blood in it. Those are all substantial risks for acquiring HIV. Those that are negligible are really any exposure with urine, saliva, sweat, tears, or nasal secretions that does not have visible blood. So those bodily fluids are thought not to be a risk for acquiring HIV. But you also have to look at the source patients. In many cases, we may know that whether the source is HIV positive or not. However, in many cases, that's not known, and we can't contact the source patient. And then you have to know something about the local epidemiology of HIV in your community. These are just some numbers that were in the guideline from Rhode Island. The seroprevalence of HIV among prisoners in Rhode Island is 3%. Among rapists is 1%. I don't know how they got that, but they have it. And the general population is quite low at 0.3%. I included some data from Seattle. So gay men in Seattle have a seroprevalence between 12 and 17%. Injection drug users a little bit less than 2%. And the general population in Seattle and Washington State in general is less than 1%. And you use those in the calculus when you're talking with patients about whether or not they want to start post-exposure prophylaxis. So this would be the decision tree. If you evaluate the risk as substantial, and if the exposure happened less than 72 hours ago and you know the source patient is positive, then the guidelines would recommend that you initiate post-exposure prophylaxis. In those same circumstances, if you don't know the source of the patient, then you have to take it case by case. If someone had sex with another man and had receptive anal intercourse, and the seroprevalence of HIV in your community is 15%, well, that's pretty significant risk, and almost everyone would treat them with post-exposure prophylaxis. On the other hand, if it was sex with a woman and it was vaginal intercourse and the woman had no risk factors or known risk factors for HIV, then maybe you'd make a decision that the risk is quite low and you wouldn't prescribe PEP in those circumstances. If the risk happened, even if it was a substantive risk and it was greater than 72 hours or negligible risk, the guidelines suggest that PEP is not indicated. But again, we'll talk about that 72-hour cutoff in just a second. So there are some new regimens that are recommended in the guideline for individuals who have normal renal function with a creatinine greater than 60. Preferred regimens are tenofovir and emtricitabine plus either raltegravir or dolutegravir, or an alternative regimen if they are not a candidate for an integrase inhibitor, then boosted darunavir. For individuals whose creatinine clearance is less than 60, then we swap out the tenofovir for AZT and just use combivir instead of Truvada, again with the same third drug, raltegravir or dolutegravir, or as an alternative, boosted darunavir. For kids, it's a little bit different. We don't have dolutegravir listed as a preferred regimen, so it's either Truvada plus raltegravir, and the alternatives include some other protease inhibitors for which children have more experience taking. And the other, we don't have to talk about the other. You can read the other preferred and alternative regimens recommended. So some other considerations that I think most everybody in this network knows, but never use nevirapine for post-exposure prophylaxis. It's associated with hepatitis and in HIV uninfected people with hepatic failure and the need for liver transplant. So that's an absolute negative. Abacavir should also not be used because you just don't know about abacavir hypersensitivity and there's not time for HLA testing to categorize somebody at low risk for that. If patients are pregnant or potentially pregnant, then you want to avoid efavirenz in the first trimester. Again, no nevirapine because there's an even higher incidence of severe hepatitis in pregnant women who take nevirapine. And no, not that anyone would use stavudine or DDI any longer, but pregnant women are particularly susceptible to the mitochondrial toxicities of those drugs, so those should not be used. Regarding whether to give starter packs of 3 to 4 days and then a follow-up with a provider to finish out the 28 days, or just give them the 28 days of therapy up front, there's some controversy. In favor of giving the starter packs, you get the opportunity to see the patient 3 days later and reconsider the decision. Some people get started on medications where maybe it was not indicated, and you can talk to them about that and then decide whether to go forward or not. You can see whether or not they're tolerating the PEP and provide some additional counseling at that time as well. On the other hand, there are data that if you give people a starter pack, that they don't show up for that visit, and adherence for the full 28 nPEP courses is better if you give them the month of therapy up front. So you have to balance one versus the other when making the decision for a particular patient. So just a reminder that overall adherence after sexual exposures to HIV is low, on the order of 40 to 66% of people will complete the full 28 days. It's lower for assault victims, for those getting starter packs, as I mentioned, and in developed countries. I think the occasional patient that's lucky enough to get nPEP after an exposure in the developing world takes it to heart and finishes the therapy, but I think people in developed countries take it more casually. There's also lower adherence rates for people given AZT or protease inhibitors compared to, respectively, tenofovir or an integrase inhibitor when those are the components of PEP. Cost-effective analysis with a threshold of $60,000 per quality of life year is only effective for receptive anal intercourse. That just means that the likelihood of acquiring HIV from an exposure that is not receptive anal intercourse is so low that the cost of averting a case of infection is much higher than that threshold of $60,000. Nevertheless, we often give PEP after almost any kind of sexual exposure. For more information, or you can refer your patients to the PEP hotline that is listed there, and there is financial assistance from pharmaceutical companies that can be obtained at the website listed. So what about laboratory evaluations? So if you're lucky enough to get the source patient, then you obviously want to test them for HIV, for hepatitis B and C, and for STDs, but many times that source person is not available. Those same baseline studies should be done in the exposed individual along with pregnancy testing if the exposed person is a woman, and then baseline renal function and liver function tests are recommended. The guidelines also recommend a creatinine and an AST/ALT at 4 to 6 weeks after exposure. I can't say that that's something we do in the Madison Clinic very often. I think that people are taking 28 days, and by the time you check those values, they've already finished the month of therapy, but that is what the guidelines are recommending. And then a follow-up HIV test at 4 to 6 weeks after the exposure, at 12 weeks after the exposure. And because of this one case of delayed seroconversion in someone who acquired both HIV and hepatitis C, if the exposed person were to get hepatitis C, the recommendation is to check for HIV at 6 months after the exposure. If that's really not a consideration, then we stop testing at 12 weeks. And handling STIs, you want to consider empiric treatment for gonorrhea and chlamydia, Plan B for women who have been sexually assaulted. And the guidelines say, and I was a little surprised at that STI prophylaxis, empiric STI prophylaxis, is not recommended for sexually abused or assaulted children. You want to test them for STIs and then treat if you find it, but treating them up front is not recommended in the guidelines. Just a word about hepatitis B. If the exposed person is unvaccinated, then start the series. If they're exposed unvaccinated and you know that the source is surface antigen positive, so a carrier for hepatitis B, then they would get HBIG and the vaccine. And if they're exposed and vaccinated but the response is unknown, the response to the vaccine is unknown, then will also be given the vaccine. And then a word about HPV. That also is recommended for assault victims, for women in these age groups, and for men 9 to 21 and gay men who are up to 26. So let's do another case maybe to illustrate the conundrum when you're having a patient with ongoing risks for HIV exposure. This 28-year-old woman, injection drug user, began sharing equipment with a new partner a month ago. She just discovered that he is HIV infected and her menses is 10 days late. Her pregnancy test is positive and she plans to complete the pregnancy, remains committed to her new partner who has no plans to start antiretroviral therapy. So the question is, how do you advise her regarding the need for post-exposure prophylaxis and the need for ongoing pre-exposure prophylaxis? And the guidelines address this by saying that if a patient's ongoing risk required sequential, which you can make the argument in this case, this woman would need constant PEP or near continuous PEP, that you should consider transitioning from PEP directly into PrEP. And that they also state that there is no evidence that PEP delays seroconversion and therefore no gap between the completion of PEP and the start of PrEP is required. So I think that Joanne Steckler brought this up at a recent ECHO meeting, that that's just patently not true, and that there are cases of delayed seroconversion and people who have been given PEP, so that I think you need to evaluate the risk that somebody had for acquiring HIV after one exposure. And if that risk was extremely high, then you might want to make sure that they didn't acquire HIV after the PEP is given before you initiate PrEP. In most cases, the risk is not going to be extremely high, and it would be reasonable to proceed from PEP to PrEP. But I think in some cases with a very high exposure, you might want to follow them for a period to make sure that they didn't acquire HIV. So I had some issues with the guidelines. So what about this 72-hour limit? I think this is based on minimal animal data, and the animal data that I showed you was that only 1 of 3 animals who were challenged 72 hours after vaginal installation of HIV-2 acquired the infection. So 2 of the animals were protected. So I don't know why the guidelines come down so hard on this 72-hour limit. Furthermore, the occupational PEP guidelines offer a softer 72-hour limit. They state, and I quote it, the interval after which no benefit is gained from PEP for humans is undefined. So I don't see why we have a guideline that's fuzzy after occupational exposure and harder after a sexual exposure. So I don't know how to reconcile those two things, and I think that I wouldn't necessarily withhold PEP from somebody if they had a very high-risk exposure and came in a little after the 72-hour limit. They also state that the risk for transmission after oral sex is almost negligible, but I think this is controversial. In one paper that was presented at CROI 15 years ago, the authors estimated that up to 8% of new infections in San Francisco were acquired by oral transmission, and a calculated risk of 0.04% for oral sex act is from this Journal of Epidemiology paper in 1999, which rivals what it is for insertive vaginal intercourse. So I think that it is controversial and people can discuss it with their patient. And for someone who had receptive oral intercourse from a source patient with untreated HIV, and there was ejaculation, that I would constitute that as a significant risk and would proceed with offering PEP. But the guidelines call the risk very low and kind of step away from making formal recommendations in that situation. And also their statement about delayed seroconversion due to PEP, the guidelines say that it can occur with coincident hepatitis C infection, but they are dismissive of other circumstances. And again, as Joanne Steckler pointed out in a recent ECHO talk, I think that that is probably incorrect. And as I just mentioned, these guidelines are not really aligned with the occupational PEP guidelines. There are differences regarding the 72-hour threshold. The recommendations for follow-up testing for the OPEP guidelines is at 4 months rather than 3 months. And the preferred regimen after occupational PEP is Truvada plus raltegravir with no mention of dolutegravir. And the alternatives that they are included in the OPEP guidelines are Combivir plus a variety of other protease inhibitors. So I think that hopefully CDC will update the occupational PEP guidelines so that they are in sync and harmonized with the nPEP guidelines. One question that I thought might come up from people would be, what about TAF? And currently TAF is not recommended for PEP, whether it's OPEP or nPEP. Rectal and vaginal levels of tenofovir alafeminate are lower than tenofovir itself, but in this animal model, TAF was protective in PrEP in this animal model. So these were macaques that were challenged with Shiv virus and were given TAF with FTC, and it was perfectly protective for those individuals. So there are some animal data suggesting that TAF does work well for PrEP and probably also for PEP, but the genital secretion levels of TAF are much lower than tenofovir. So until there are human studies showing that TAF is effective for PrEP or for PEP, I don't think we should be using it. We should stick to tenofovir. So in summary, evaluation for nPEP should be less than or equal to 72 hours after the incident. Use a rapid antigen antibody or antibody testing. If those are not available, then just start nPEP right away and get the testing later. The issue about no nPEP after 72 hours, I think, is a little fuzzy, and you can make your own decisions about that. Preferred regimens are Truvada plus raltegravir or dolutegravir, alternatives being Truvada plus boosted darunavir. Don't forget to treat for concurrent STDs and for possible pregnancy. And for those individuals who present after an HIV exposure and have ongoing risks, and that is anyone who's had more than one PEP course within a year, then you should consider those individuals for transitioning over to PrEP. So I'll stop there and take any questions.